And right now, we've got a special guest lecturer, Dr. Vincent Cimmino from Ann Arbor, Michigan, and the University of Michigan. We'd like to bring him down here for our meetings, particularly to talk about the topic that he's going to address, because Dr. Cimmino has dealt with cancer in general and with melanoma in particular in different settings. He started his career in private practice, first in New Jersey and then up in Michigan. And then when I was still in Michigan, we hired him to join the Department of Surgery and the Division of Surgical Oncology up there. And he got to see the difference between taking care of melanoma in a private practice, individual sort of specialty way, from a team approach that is very similar in many ways in Ann Arbor, not quite administratively similar, but at least in terms of the patient care model, very, very similar. And so it gives him a unique perspective, and we're delighted to welcome Vince down from Ann Arbor, even if we usually hope it was really cold up there, it was warm in Michigan, but we'll just have to deal with it anyway. All right. Thank you, Vince.
Well, first of all, I want to thank the people who organized this conference, and I'm amazed at the number of people who actually have come here on a Saturday morning. It truly is inspiring to see that. And I want to personally thank Vern Sondak for inviting me. I do have somewhat of a unique perspective, as Vern said, because I was in the private sector for many years before I came back to the University of Michigan. I was originally trained there, so I do have a perspective on what private practice is like versus what it's like to work in a center such as Moffitt. And I do want to tell you that the concept of multidisciplinary care certainly exists here at Moffitt. We do it a little bit differently maybe at Michigan, but the concept is the same. So we can just go ahead and I'll start off and tell you that some things that you've seen before are the fact that the incidence of melanoma is rising at sort of epidemic proportions, because between the years 1970 and 1990, you saw about 100% increase in the number of cases of melanoma. It's currently the 5th most common type of cancer, and about 1 person in every 70 minutes dies from a melanoma. Now, I don't want to put a damper on things, and I think Dr. Weber has shown that we're certainly making some progress, and I think we will make more progress over the next decade or so, and the research that's being done is very encouraging, but currently this is the number that we're seeing. So our projected money that we're going to spend on melanoma treatment in this country this year is greater than $5 billion, which is a fair amount of money. Okay, so why should we develop a multidisciplinary clinic? What's the benefit of doing that? First of all, always to optimize patient care. You want to support and promote your basic science and clinical research, which clearly is being done here. And you want to partner really with the people and network with the people in the community, and those are the physicians who practice in the community, because one of the problems you always have in private practice is the town and gown effect, and I'll explain that a little bit more as we get into the talk. You really can't deliver good care if you have that problem existing, and that's a tough barrier to break down. So in Michigan, at the University of Michigan this year, you can see that in 1990, we actually treated only, let's see if I can get this to work, only about 126 cases of melanoma at our melanoma clinic. You can see that in 2009, we projected about 1,450 cases, and the numbers just came out, and in fact, it's closer to 1,500 new cases of melanoma were treated at the University of Michigan, out of 2,240 that were diagnosed in the state. Well, one might say, well, why do we have so many cases of melanoma in the state of Michigan? The sun doesn't shine there. Basically, I would tell you that it has a lot more to do with sun. It in fact has to do with probably a lot to do with the ethnicity of the people who basically inhabit the state of Michigan, and most of those people are fair-skinned and from fair-skinned ethnic groups. and therefore they do have a high incidence of melanoma. So one of the things that you have is the problem with the traditional system of melanoma treatment, and that can be very problematic. Why is it problematic? Because you have individual physicians who work patients up differently, they treat patients differently, and what happens is you have inconsistencies in the management of these patients. So in the private sector, you have what we call turf battles. Turf battles are, if I'm a private practitioner, I'm trying to keep the patients in my office. I want them in my office. I don't want them going someplace else. I don't want them going to Moffitt, because if they go to Moffitt, I may lose that patient. And that's the mentality of the private practitioner. I will definitely tell you that's for sure. So you may have delays in treatment because of that. And why do you have delays? Because if you go to Dr. A, it takes 2 weeks to get an appointment with Dr. A. If you go to Dr. B, maybe it's another 2 weeks to get an appointment with Dr. B. So by the time you get to Dr. C, your disease may have progressed more than you want it to progress. So that is a major problem. So coordinated, centralized teams are certainly better. Most of the time, you're going to have people who have state-of-the-art knowledge, such as Dr. Weber just explained to you. You're going to be able to increase your caseload, and anytime you increase your caseload, most of the outcome studies that have been done today will tell you that high-volume places do a better job of taking care of patients. There is absolutely no question about that. So if you take your, and I'm not trying to knock a small community hospital, but if you take a 250 or 300 bed hospital someplace out in the middle of nowhere, basically they're probably not going to have the caseload that's going to give them the experience to treat these things with state-of-the-art treatment. And I think that's very, very important. So the other thing that you have is it's cost effective. It's one-stop shopping, basically, so-called one-stop shopping. So when you have a patient who comes to Moffitt, or you have a patient that comes to the University of Michigan, we can do almost everything for that patient in one visit, except do the definitive treatment, of course. But we can actually do all the paperwork, diagnosing, set up the surgeries and so on in one stop, which is, I think, extremely important, and important for the patients, because many of them come from a long distance. And we also have access to clinical trials. Again, such as Dr. Weber has mentioned, they're doing unique and novel things here that they're just not doing in most places. So I think that that's a very important thing for the patient. Okay, so in our particular model, which you don't have to have, it can be different in every different model, but in our model, most of the patients are directed through the dermatology clinic. We have a very active dermatology clinic. We have a couple of individuals who run that dermatology clinic that have been very effective in communicating with the physicians in the periphery and actually creating a very good atmosphere to work in, because those physicians now are not afraid to send their patients to us. They know they'll get them back, and that's what they want. They want to know they can get those patients back. So what happened with our cancer center, as Moffitt is essentially a cancer center that has been designated as a comprehensive cancer center by the NCI. And by the way, Moffitt is the only cancer center in the state of Florida that has been designated by the NCI as a comprehensive cancer center, and you should make that known to the public, because I think that's most important. The strength of the program really lies in cooperation and participation with the multidisciplines. That really is where the strength of these programs is. The absence of turf wars is most important, because it allows us to have a common interest in the patient. It allows us to give good patient care and educate the patients properly, as well as educating the physicians who are out there doing the sort of road work and groundwork, if you will. Now, what happens and how does this work? Typically what happens at Michigan is a patient will come in already having a biopsy confirmed with a diagnosis of melanoma. Usually that patient is referred in by one of the dermatologists or healthcare professionals out in the periphery, or they're self-referred. A lot of patients come in because they know Michigan is a cancer center. They know Michigan treats a high number of melanomas, so they come in because of that. They actually make the request themselves. We have a nurse coordinator that initiates that treatment, takes the referral call, and the effort is always made to expedite the process. When I say expedite, I mean that we will not have a patient delay any more than 2 weeks before they're seen. And we're actually trying to decrease that as time goes on, and I'll explain why a little bit later in my talk. Now, this is what we call a centralized hub, or the dermatology model of that centralized hub. Now, you've got to get, the problem with having a centralized hub is this: you've got to get somebody to agree to work in the red. And that's pretty hard to do. Now, if you start a business, I don't think you want to work in the red, do you? So essentially, you have to get somebody in your institution to say, I'm going to work in the red, so that the people down the line can benefit from that. And that's what you have to do. And the Derm people in our place have been good about doing that. Not to say they're starving to death, by the way. So I would say that all of these other specialties that you see here are all specialties of people who attend our multidisciplinary clinic on a fairly regular basis. Some of these infrequently, but almost all of them attend the multidisciplinary clinic. And I'll explain that to you just exactly how that meets. If you look at the University of Michigan's Medical Center, if you include non-melanoma skin cancers, that represents, and melanomas, that represents about 40% of all the cancers that are treated at the University of Michigan. If you exclude the non-melanoma skin cancers, melanoma represents about 19% of all the cancers that are treated at the University of Michigan. That's a pretty high number when you consider the number of cancers that there are. If you look at the breakdown of the different skin cancers, it's pretty typical of most places. Basal cell carcinoma represents about 79 or 80%. You've got about 14 or so % of squamous cells, and melanoma represents about 5%, and about 2% are others. Now, when I say others, I'm talking about things like Merkel cell carcinomas and some of the unusual ones. Now, Merkel cell carcinoma, interestingly enough, is not becoming so unusual anymore, and in fact, we have a multidisciplinary tumor board just for Merkel cell carcinomas now. So it's becoming that frequent. So how do we do this? Well, first of all, we take a nurse coordinator, and she makes the initial contact. She's the intake person. She takes all the information, develops gets all the demographic information, finds out who the referring providers are, gets all the records and slides, which are most important. And I'll tell you in just a little bit why that's important, because the slides that come from outside institutions, we often change the diagnosis on those slides. And in fact, in about 20% of cases, we will change the diagnosis on something that's come from the outside. We have very good derm pathologists, similar to Dr. McCardle, and they, again, will clearly change things when they see what the diagnosis is from the outside. So again, it's that issue of people from smaller institutions do not see as many of these cases. Therefore, their expertise is probably going to be somewhat limited in making the diagnosis. I don't want to say it's going to be terrible. I'm just saying that, again, the higher the volume, usually the better you do at taking care of things. So we have a nurse coordinator that makes direct telephone contact with the patient. The nurse records all the information, gets all the data and everything that we need, so we really don't do much of anything, I guess. We basically do the surgery. So in effect, the maximum wait is, as I said, about 2 weeks. If the patient is extremely anxious, somebody will call them that evening after they've called in, and it will be one of the physicians that calls them, so that we can try to calm them down a little bit and try to relax them before they come in, and reassure them a bit if we can. Again, the nurse does all the work, makes all the gives them all the directions, tells them what the cost of the visit's going to be, tells them about support groups if they need support groups, and many of these patients do because they come from rural areas. They don't have a lot of support where they are. Many of them have familial issues and don't have a lot of support. So we try to encourage these people to interact with our support groups that we have available for just about all malignancies now. We then will mail out their appointment date, we'll give them maps, we give them all the information, and we send them a video. Melanoma video is mailed in a packet so that they have some idea of what's going to happen to them and what this disease is all about. The clinic visit itself, well, we see new patients, well, I shouldn't say we, I should say the dermatologists see new patients every Wednesday in the melanoma clinic. That's typically the day that all of melanoma patients come in. Every other Wednesday is when we have our multidisciplinary tumor board, so that the patients who need to be in the multidisciplinary tumor board will only be seen on every other Wednesday. And all of the pathology that comes in is reviewed by our derm pathologists. It's all available for the conference when we have the conference. The new patients are always seen by at least 3 of the derm consultants and 2 or 3 fellows, which we have many. The melanoma education is really provided for the patient, and everything is handed out in a packet for them. The appropriate tests are ordered according to the guidelines that we've established. And all of these things are discussed with the patient and the family. And usually patients come in, they're accompanied by a fair number of family members. And what happens then is that the tumor board generally meets, if they are a patient that's going to be in the multidisciplinary tumor board, that meets at about 3:30 in the afternoon, again every other Wednesday. It runs for anywhere from between an hour to an hour and a half. And during that tumor board, the deep melanomas are the ones that are generally discussed at the tumor board, because those are the ones that are generally going to be given to one of the other subspecialties. The dermatologists typically do not handle the deep melanomas. They will usually be handed over to surgical oncology, possibly plastic surgery, possibly the ENT people, depending upon the location of the melanoma. So basically, that's how we run it. And then when the tumor board ends at 4:30, if the patient is one that's going to be sent, for example, to me as a surgical oncologist, I will see the patient that day after the tumor board meets, sit down, discuss the surgery with them, and say, okay, this is what we're going to do, how we're going to do it, do you have any questions, and so on. And that's routinely how that works. So this is just more or less a diagram of exactly what the dermatologist does, what they do, how they educate the patients, and so on. And essentially, all of that pre-op information is done. We also have our coordinator or our scheduler present at the end of the conference, so that when the patient gets done talking to me, they then go to the scheduler, and the scheduler sets their surgery up that day. So they know exactly, before they leave that day, exactly when they're going to be operated on. Okay? And after we've developed a plan, if you will, and sometimes developing that plan takes quite a bit of discussion, because obviously we have people from different specialties, they have different opinions, and we try to put that all together in one package and then present it to the patient as a final plan and say, okay, this is what we agreed upon after we talked and discussed this in the multidisciplinary tumor board. And after the conference, again, we meet, we talk to the patients. Some of the patients have a strong family history, and we have geneticists available that can talk to the patients about particularly about potential genetic testing. We have psychosocial counseling. Some of the people, as I said, come from backgrounds where they may not have a very good support system. Those people may need a psychologist to help them. They may need a social worker that is going to help them with their travel plans and their logistics. We provide all of that at this multidisciplinary meeting. And the patients are always encouraged to contact the nurse after they leave. If they have any questions, we have a nurse coordinator that they can contact at any time. And that individual will hopefully supply them with some of the answers. If they can't, they will contact one of us, and we'll then contact the patient and try to supply them with the answers. So we get after the clinic is over, we have a comprehensive note that's made, a chart, a letter that goes into our system. We have a computerized system called CareWeb at our place, which has all the patient's records that are treated at the University of Michigan on it. So for me, it's a very simple process. If I want to know something about a patient, I punch in their what we call CPI number, and basically I can get all the information I need to about that patient, what they've had done, what their past tests were, what their present tests are, and so on. So it's a very, very good system. We're very fortunate to have it, and I think most places that are the size of a Moffitt or a Michigan are probably developing that system as time goes on. It's an expensive proposition and takes a lot of money and effort to put into place, but we're lucky to have it because in the old days we used to fumble through these charts and half the stuff would get lost, and by the time we found anything, half your day would go by and you'd probably see about 3 patients when you could have seen 23. So we then have a data form that we make up that's sent into our data manager. So we have data sheets and registries for all of these patients. And then the day after, one of the providers will call the patient and talk to them about what was discussed and ask them if they have any questions, anything about what was discussed at that meeting. Again, this is just a scheme of what I just mentioned to you. It's that the specialists are all assigned individually. Now, how do we assign these specialists? Well, we assign them because at this multidisciplinary meeting, if, for example, the tumor is on the extremities or the trunk, generally, if it's a deep melanoma, okay, then we're going to do it because we have to do a sentinel lymph node biopsy, and dermatologists don't do sentinel lymph node biopsies. So they'll send it to one of us as a surgical oncologist, and one of us will then schedule the patient and do what we have to do. If, for example, the lesion is on the head and neck, in the head and neck area, well, I don't operate in the head and neck area very often, so generally that's given to one of the plastic surgeons, or it's given to the ENT people who are also present at that conference. So these things are distributed often according to where the melanoma lesion is located. Now, what benefits do we have here of basically this particular type of a model? Well, we have, first of all, you've got coordinated access, as I've explained, and communication. You've got nurse coordinators who are good liaisons with the patients, they're good liaisons with the providers in the periphery, and they maintain that connection and that contact, which is extremely important. The nurse coordinator's office is managed by 100 hours a week of registered nursing and about 40 hours per week of a clinical clerk. Communication is really between the communication between the multidisciplinary physician or physician extended team member and community is encouraged, and I can't emphasize that enough. And I must tell you that I am not responsible for having developed that. I can tell you that we have one of our dermatologists who is extremely good at public relations, and of course Vern knows him very well, and that's Tim Johnson, is an outstanding guy, and probably if he worked in the private sector as a businessman would be a multi-zillionaire, because the guy is just fantastic at developing connections with outside people, particularly outside physicians. That is why we do not have this town and gown problem in Michigan, because of people like Tim. It has, again, little or nothing to do with me. So in any case, I want to really emphasize that that's important, and that's what really has broken down this issue of being individuals versus being people who have a coordinated and a well-disciplined type of care. The coordinated multidisciplinary care that follows evidence-based, and I want to emphasize that. What we do in these centers like Moffitt and Michigan and places like MD Anderson is all evidence-based now. So we've done tests, we have proven why certain things work and certain things don't work. We are in the process of still proving why certain things work and don't work. And as Dr. Weber so eloquently pointed out, we are making significant progress now in treating these tumors because of the quality of the research that's being done. And the identification of the human genome has really helped us significantly in our treatment of these particular types of problems. So these strategies are developed, and it gets away from the decentralized care that exists in most places and totally centralize it. We realize that the university includes this network, and we want to emphasize the partnership that we have with the people in the private sector. Okay, well, the community providers are responsible for recognizing the melanoma typically. Well, how do they learn how to do things so that what they send in to us is reasonable and respectable? Well, we teach them, simply put. It takes a big effort. We go out to the periphery. All of the people who work in melanoma care, be they dermatologists, surgical oncologists, whatever they are, spend time out in the community talking to the community dermatologists, talking to the community physicians, and telling them this is how you're supposed to do the biopsy, this is what you should do, and this is what we would like to see when it comes in to the university so that we can make an appropriate plan. And they're very receptive to that. That really is helpful. Now, our model is, of course, responsible for the initial consultation, all the follow-up and so on. We do. The initial work they do. But I want to emphasize that the patient goes back to that provider. We do not, and I'll show you why a little bit later, but the patient goes back to the provider, which is what they love, okay? The cost of the initial visit is really standardized. There's really two bills. One bill essentially comes from pathology, and the other bill comes from all the other physicians that participate in the care of this patient as one global fee, not individual fees. So it really is cost effective. The melanoma clinic serves as sort of the storefront, and I mentioned to you that somebody has to be the storefront. It doesn't necessarily have to be derm. It could be some other specialty. It could be cutaneous surgery. It depends upon your model. But somebody has to be the storefront. Somebody has to say, okay, I'm the guy that's willing to do this work. I'm the guy that's going to be operating in the red, but the other people are going to see the benefit of that because what you're going to have is downstream revenue, and that's what you want. So basically, I would say that the red ink thing is the hard thing to sell. The storefront really provides the fiscal value and the high volume and subsequent treatment revenue for the rest of the institution. All right, so comprehensive care, the obvious strength of this is the patient care. I mean, ultimately, that's what we're trying to do. What we're trying to do is make it better for the patients. That is the ultimate goal. The team-oriented approach is most important. Approximately, again, I told you 20% of all patients initially seen in the Multidisciplinary Cancer Center have an altered diagnosis by our derm pathologists. Education is important. We do try to, again, educate the people out in the periphery, and it's very important that everybody is sort of on the same page. The team-oriented approach fosters that. It's invaluable. It's an interchange of knowledge and experience that works. It's very beneficial to have people from the individual specialties right there. For example, our clinic is right down the hall from the dermatology clinic. So if I have a patient comes in that I see a derm problem in, I mean, I'm not a dermatologist. I don't know as much as they do about dermatological illnesses. I can walk right down the hallway and say, you know, Tim, would you come over here and take a look at this? I'm not sure what I'm dealing with here. What do you think it is? And there's a real benefit to having that available. Again, if you were out in the private sector, you couldn't do that. You'd have to send it to Dr. B, and it may take 2 weeks or 3 weeks to get in to see Dr. B. So there's a tremendous advantage to this multidisciplinary approach. Research, no question. We've already heard Dr. Weber's talk about the research. There is no current satisfactory treatment for stage 4 disease in melanoma. We know that, but we're gaining. We're definitely gaining. This is still pretty much a frontier that we haven't really overcome, and we are in the process of doing so. And I think over the next 5 years to the next 10 years, we will see tremendous strides made in the treatment of this disease. But right now, surgery is still the best treatment for melanoma as it stands currently. And I'm not saying that just because I'm a surgeon. The high volume of caseload really facilitates a lot of things for us. It really helps us develop, for example, clinical trials. Clinical trials are very, very important. We need to have enough patients come into our institution so that we can begin these clinical trials, then publish the information that the clinical trials reveal to us. And if you don't have that volume, you're just not going to be able to do that. Now, here's essentially just a little diagram of some of the things that we do, and I'm sure are done here, just the same as ours. We have an internal review board that reviews all of these protocols before we can do any type of a clinical trial. It has to be approved by our internal review board. We have researchers doing work at the molecular level, again, as Dr. Weber has described, trying to interrupt the different pathways that occur in these malignancies. We also have people who are doing mouse research, animal research, trying to develop vaccines that might be helpful in the treatment of this disease. And so far, there's been some progress made, but we haven't obviously done anything that's going to eliminate this disease at this point. Again, the value of this whole thing is essentially you've got revenue downstream that goes to the other specialties. You've got academic manuscripts that we produce that hopefully will inform other people. We obviously need grants to do this research, and it provides the patients to get what we call R01 grants from the National Institutes of Health. And it supports the education mission, which of course is important because we are a university. This is typically just a scheme of what happens with a patient. The biopsy-proven melanoma comes in, goes to Derm. The Derm then, if it's something they're not going to take care of, they deal it out to whatever specialty needs to be to take care of it. Then after the patient is treated, they go back to the physician. And again, I want to emphasize that. These are just a group of the people that work in research in melanoma at the university. Just the only thing I want to point out is all of this has produced in the last 5 years some 109 manuscripts by 40 different authors. So as you can see, there's a significant amount of research being done. If we didn't have the volume that we have, we could not do this. It just would not occur. These are just the people who are in the multidisciplinary tumor board routinely. These people are periodic visitors depending upon what type of problem that we're dealing with. We may invite one of these other specialties in to come in because it's in their area of expertise. Now, we talked about, one of the things we talked about was the question of how many people can you treat? Well, there's a limited number of people you can treat. You have X number of staff, you have Y number of patients. You can't treat everybody. Who we want to treat are the people who are the new patients. Those are the patients that we want to see. There's less overhead involved in treating them, and those are the ones that we prefer treating. The return visits, we prefer going back to their own physicians. And if you look at this year going from about just before 2000, you can see the difference here in the number of patients that were new patients versus the number of return visits. At one point, in the beginning of 2003, the ratio was 7-to-1 in favor of the return visits. Well, that's not good. It's not efficient for us, and it's just not going to help us because we're not going to get to see enough of the new patients quickly. So what we then decided was, okay, let's do something about it. So they had a meeting, and this is when Dr. Sondak was still a member of the University of Michigan's Surgical Oncology Department, and decided, well, how are we going to do this? How are we going to change this trend? Okay, what are we going to do to make this different? So what we want to do is we created this statewide network that I talked about. There were hours of calls that took place in order to make that happen. And what we actually successfully did is by the end of 2003, we were able to change the difference in the return visits and the new patients. We were able to flip it around, and we were seeing more patients that were new than we were return visits. So what did that do? Well, obviously, it gives us more new patients to take care of, therefore more information that we can glean from these new patients. And again, it made the people in the community very happy because the patients went back to them. And that's what they want to see. The other thing is that the new patients have a better payer mix. And there's no question that we have to think about the economics of this as well. I'm going to skip this because I see Verna's getting a little antsy over here. So I'm going to just go to our intake model and just emphasize here. Look here in 2003, toward the end of 2003, you can see our new patient visits outnumbered our return visits. Now we have roughly about 3,200 patients that we see a year in the melanoma clinic. Most of these, in fact, are new patient visits. We still see some return visits because some of the patients just don't want to go anywhere else, and there's nothing we can do about that. So in conclusion, I would tell you that multidisciplinary care for melanoma is greatly beneficial in respect to the patients. It's cost efficient, outcomes are better, education is better, and it provides us with research. So centralized care, I really believe, is much more effective. Now, if Vern will have a little patience, I'm just going to go just ahead just a second, and I'm going to go ahead. Now, you understand, I'm going to mention something to you that's happened at Michigan now, and because Michigan is one of the states that's been hit hardest by the economic downturn. Essentially, because of the auto industry going in the tank, basically, what has happened in Michigan is that the unemployment rate now is above 14% in the state of Michigan. That is the highest in the country. So what does that mean to us? It means, where are we going to get our patients from? What kind of insurance are they going to have? And what's that going to mean to us as a medical center? We have to do something to mitigate this and to change the trend. We cannot depend on Michigan's economy any longer. So in effect, what we did was had a retreat in 2007 when essentially all these things began happening, and we decided that we would then take on these destination programs. What's a destination program? Well, destination program means we're trying to sell what we're doing to people outside of the state of Michigan. So in essence, what we're doing is advertising, simply put. We're trying to use our reputation, which in most parts of the country is probably pretty good, and we're trying to capitalize on that reputation and in fact create a model that is similar to the Mayo Clinic, Cleveland Clinic, and MD Anderson, which they've used for years. In effect, try to bring people in from the periphery. But in order to do that, what you have to do is make your care more efficient. You can't have somebody calling from North Carolina and saying, doctor, I'd like to be seen at your medical center. When can I be seen? Well, you can be seen in a month. Now, that doesn't work. So what you have to do is say, as soon as you can get on a plane, you come here. We'll take care of you. We'll take care of you within a day or two. We'll have everything taken care of, and we'll supply all the care you need and get you on your way back to your own state as quickly as possible. And that's, in effect, what we're trying to do now in the areas of specialty where we are the most efficient, and Derm is one of those areas. We do have a couple of other areas that we are pretty efficient in, and we're trying to promote those as well. And as time goes on, we think that'll spill over into our general care of all the population that we see, and that, in effect, is what we're doing now to try to mitigate the problem that's happened in Michigan. And I wanted to mention just one thing about the payer mix. This is kind of the payer mix that occurs when people come from outside of the state of Michigan. So it's pretty good. And I'm going to end there because I think Vern is getting real nervous now. Okay.